Very good morning to all of you. I think I will straight away go to the topic. Can you see what is this embryo? This embryo is 3 or 4 weeks. Can you see the heart? And the bluish one is the respiratory diverticulum. The respiratory diverticulum arises from the foregut. That is what the lung starts. After that, it goes into 5 stages. By embryonic stage itself, major divisions are formed. By pseudoglandular stage, the airway divisions go up to bronchioles. By canalicular, even the respiratory acini are formed. Actually, these signaling molecules plays a very important role in the development of lung, particularly this FG10. Let us go to the few cases. I want some interaction from the youngsters because you yourself, you can judge how much you can diagnose with the X-ray. I'll just give you a scenario. 8-year-old and presenting with a cough, wheeze, distress, repeated antibiotics. Actually, this child, 8 years, treated as asthma and referred as a collapse. What could have been? It is from the remote corner. Okay, this is a real case. But when we do a bronchoscopy for a collapse, I could not see any carina at all. Okay, instead of a carina, that bronchus, there is absence of right bronchus, and the trachea continues as the left main bronchus. I think this is also happening, and because we thought collapse, but it's not so. Okay, it is a agenesis of lung. I fully agree that making a diagnosis of all this agenesis hypoplasia complex, CT is a very best modality. That is MDCT nowadays. Either you can go for contrast or even without contrast, MDCT is the one. Look at the agenesis. That is on the first slide. There is agenesis on the right side. You could not see any lung at all. Whereas in hypoplasia, if you look at the CT, you can see the lung. Can you see the marker? Anybody? Marker? Okay, that is a way you can make a difference. Which one? This one. See, most of the times you confront with the hypoplasia. Okay? When you see the lung, then it may be a hypoplasia. Whereas in agenesis, you could not see, and it is a total shift of the things to that other side. I think this is for the student purpose, and even for the examination they ask, you look at the bronchial bud and the lung bud. Okay? If both are absent, that is a agenesis. Very simple. If both are present in a small reduced form, it is a hypoplasia. But invariably, either extremes will be happening. Okay? You need to see only a bronchial bud and lung bud. Both are absent. See, that is what I have shown the case. Instead of carina, it has directly gone to one side of the bronchus. Usual presentation is a secondary pulmonary hypoplasia that comes after because it goes along with renal agenesis or urinary output obstruction along with the diaphragmatic hernia. And if you go into the history, there may be oligohydramnias. Okay? And even CHD, that is because of the reduced pulmonary blood flow, we get secondary pulmonary hypoplasia. And this is the child. Actually, those days we do a lot of bronchoscope, and this child has been referred for so many indications. We have done a bronchoscope. You can see the entire mediastinum, she is shifted to the left side. And you look at the bronchus, the orifice, left side bronchus is very small. We make a diagnosis of even hypoplasias even with the bronchoscope. Again, this turned out into a primary pulmonary hypoplasia because it is really, these conditions are, when compared to secondary, it is a lethal, and a child referred from abroad, stayed here for, and suddenly died. Such things also possible in primary. Actually, for the youngsters, if you happen to see any congenital lung, kidney, ovary, thyroid, do DACR mutation. I think this is the area of genomic studies. You have to see, just now we have been reading about the artificial intelligence. Everyone, if you make a study, you find out a genomic, then you put into that, and one day we can easily make a diagnosis like that and all. Next, this is a 6-month-old actually presenting with a cough, fever, respiratory rate is very high. Anybody? Can you look at the X-ray? Is it normal X-ray? Can you see that? What is that? What is that? Yes, there are a lot of cysts are in, and if you say cyst, that is more than enough. And we have gone for the CT. CT gives a very nice picture. Look at the cyst. It is a cystic adenomatoid malformation. Now the terminology is changed. Now we have to call it as congenital pulmonary airway malformation. That is why I want to say that. Okay, sometime before, Stoker classified into 3. That is macrocystic, microcystic, and solid lesion. Okay, this is also exam question. Sometime these macrocystic and microcystic they constitute the maximum, and actually they have a little better prognosis when compared to a solid one. Okay, otherwise nowadays the classification is entirely changed. According to the Stoker's revised classification, 2 additional things are happening. That is type 0 and type 4. I think what is this? I don't want to waste in this, because actually look at the tracheal divisions. Anything that happening in the trachea or anything happening in the acini, they are all getting added up. In that way, instead of 4, now it becomes, instead of 3, now it has become 0, 1, 2, 3, 4, like that. 5 classification. But type 1, that is the one, the CPAM originates from the trachea or major divisions, we have a incompatible. Like that, anything that originates in the type 4, in the acini also, actually they may associate with the pleuropulmonary blastoma. Sometimes it's very difficult to differentiate between these 2, even with all the investigations, unless you go for histopathology. This is a neonatal point of view. At CPM is an unpredictable growth. I can say that up to 6 weeks, it will grow very, very fast. Sometimes the parents will come and show to the pulmonologist, sir, this is the antenatal seat, the ultrasound report and all. After 28 weeks, it reduces. That's the reason why don't make a very categorical statement by looking at the prenatal ultrasound report. And nowadays, what they say, the CVR ratio is very important. If the CVR ratio is more than 1.6, these children should be referred to tertiary hospital. And nowadays, in Western world, they even do exit procedure. You all know that exit procedure. Actually, the placenta used as a support. And they taken the baby, they drain the CPAM, put the back, and we have a normal diet. This also possible. I think some of our places also do like that. Then, what to do CPM? If symptomatic from the infancy, you go for surgery. Straight away, either a plain surgery or VATS. Or if it is a type 1 has a pre-malignant potential, and you also to be removed. But other CTs sometimes followed up as a team. At one point, you can do it. And these all the congenital lung malformations, I don't want to discuss. This is a second case. You can take 6-year-old presenting with a cough, fever, hemoptysis, like 2 admissions. Can you see that opacity? What is that? Just now they have been telling about the persistent pneumonia. See, you have to, whenever anything happening in a younger age group, you always think of congenital lesion, but somehow SECT has helped us. And sometimes CT angio or MRI angio will nicely depict that it is a pulmonary sequestration. Actually, sequestration is 2 types, intralobar. It doesn't have a separate pleura, okay? Whereas extralobar, it has a separate pleura. And I think this knowledge is very, nowadays, hybrid lesions also getting reported. We have to have adequate knowledge about that. And coming to the intralobar sequestration, actually it's a very common one, but it may present either in the child, even up to adult. But most of the time, it is extralobar sequestration is presented, diagnosed in the neonate, and that's removed. Actually, what I want to say that even though it is a non-functioning tissue, you have to demonstrate the systemic artery supply by doing CT angio or M angio that suffices the diagnosis of sequestration. Third case, anybody? What is this? Any mass? If mass is happening in the paratracheal region, that too on the right side, what do you think of? It's not a persistent pneumonia, but this knowledge is very important. And anything happened in the paratracheal region, okay, think of, you have to go for sect, and it is a bronchogenic cyst. Bronchogenic cyst, actually, if you look at the timing of the cyst, it is started very early. I am telling you, this is when the foregut, like a respiratory diverticulum develops. Bronchogenesis also develops from the foregut, and it invariably a single or cystic spherical closer to the mediastinum. And once you make a diagnosis, you have to have a elective surgical resection. So the timing of the insult is very, very important. And anything happen in the younger age, actually that is a younger period, embryonic and pseudogallender, they have a lot of stenosis, aplasias, sequestration, cysts, all these things are all possible. And we will just show that this case present as a recurrent pneumonia. We all know the diagnosis of recurrent pneumonia, clearing, getting appeared, that has been going for a long time. But recurrent pneumonia works need a very big one. You have to load out so many things. Your clinical history is very, very important. Okay, starting early, multi-system, go like a CID, and anything with a malabsorption, go for like that. And once you suspect any structural lesions, go for this. Actually, this child is proved to be a what type of fistula? Anybody? H type of fistula. Actually, anybody who had done the bronchoscope, but this is the most difficult one diagnosed because you may miss while do the bronchoscope. You can do only while take the bronchoscope. Actually, these type of fistulas, everybody knows that is the one that present in the newborn period, and this H type of fistula that present in the later. It can present even in the adolescence. It goes like a pneumonia, recurrent pneumonia. Actually, though it only form 4%, and it goes unnoticed for a long time, unless you think in your mind, back of your mind. So I will complete some of the minor lesions. See, for example, most common thing is congenital lobar emphysema and alveolar capillary dysplasias. Actually, these are happening little later, probably in the not in the pseudocondylar, that is happening in the canalicular stage or even the saccular stage. This is a 7-day-old baby presenting with a grunting. Can you look at this one? What? There is a mediastinum shift is there, and whenever there is a mediastinum shift and the hyperaeration, mediastinum shift, you can think of congenital lobar emphysema. Now, this is mostly due to cartilage defect. I still remember a story. Actually, child is brought by a surgeon, 9th month, for repeated V's. We had done a bronchoscope. We all thought it is a congenital lobar emphysema on the left side, but finally it proved a severe malacia at the left main bronchus. See, if it is not presenting very early and is subtle presentation and actually delayed, sometimes they go even unnoticed up to 1 year. These are the one you have to do a bronchoscopy to rule out either they are associated severe malicious and all. This is a congenital lobar emphysema. Actually, lobectomy is the treatment of choice. Now I will show one or two minor anomalies. Can you, anybody say that, what is this one? It is normal, it is not a normal trachea. What is this trachea? Normally it's a C-shaped cartilage. These sort of things is a tracheomalacia. It's a very common one. Even in Nelson textbook says that any child presenting with below 1 year recurrent V's and not responding to the medical treatment, think of that. These are the bronchomalacia. This is a normal one. If any child is not responding to the beta agonist and is keep admitting below 1 year, think of malicias. Maybe trachea, bronchomalicias, and things are possible. And the last one, I think this has been treated as a persistent pneumonia on the right upper lobe. Admitted several hospitals. Finally, we done a diagnosis, it's a tracheal bronchus. See, tracheal bronchus, I am repeatedly telling any structural lesions, any radiological lesions that is happening in below 1 year, that is not responding to the medical treatment, think of these structural things. Actually, this originates from the side. Okay, these are the three types, and three types of tracheal. You can see it may is a displaced one, or a supernumerary, or it may be something like a pig bronchus also is quite possible. Last one is a child presenting with a biphasic stridor. We done a bronchoscope. Bronchoscope shows this is the one that is proved to be a congenital subglottic stenosis. And these are the conditions. Once you make a diagnosis, actually the acquired one is very common. When you happen to make a diagnosis, then you have to go for laryngeal reconstruction with a cartilage graft and all. Last, anomaly. Anybody want to make a diagnosis? Sorry? Yes. Thank you. Thank you. All made a very correct diagnosis. I am saying that congenital lesions are may regress in utero. Don't make any solid statement. Somebody come with a prenatal ultrasound report. And after birth, that contrast CT and MDCT plays a major role. Most of the symptomatic lesions need elective surgery. Nowadays, VATS play a very major role. Such type of fistula may miss for a long time. Even intralobar sequestration can be present as a RRI for a long. Strong suspicion is very, very important. And some lesions have malignant potential. The classical one is CPAM type 1 and all. And keep doing some DCR mutation if possible. So one day, this may be connected with some of the congenital malformation. I think last slide. Thank you very much.
Sir, it was a beautiful presentation. Any questions from the house?
Yes.
So one thing, which are the ones which are commonly picked up by the anomaly scans, and are there any ones which we will recommend that if this is present, we have to go for terminating of pregnancy?
I think most of the CCAM or is a very big one that will be easily fixed by the anomaly scan and all. And I think it all given, see if it is associated eye drops, okay, some of the lesions go along with eye drops. If it is going to the eye drops and you have to give a choice to the parents, it is happening when very less, you can go for termination of. Otherwise, if you are going to direct after 24, 26 weeks and all, I think you need a very big discussion. And most of the, if it is CCAM, there is a chance of regression is quite possible. Okay? You can give a wide discussion for the parents. They may be a very precious child and all. Now, even exit procedure is available and all. Many centers are doing that. And we can do, it's not a, it is a team effort. You have to have a very detailed discussion, repeated prenatal ultrasonogram, then finally you have to come to some conclusion.
Thank you, sir.
Yes, exit is not a thing. See, just before end of your pregnancy, see, for example, normal pregnancy, no, they will make it 3 or 4 weeks earlier. They do a same LSCS and they use placenta as a support. Oh, till they do all the procedure, then put it back or they deliver. That is the exit procedure. I think some of our friends also, I came to know that the nursing homes, they have done some of the cases also. These are all appear to be very big. I think what has been happening in the Western world, our people are competent to do much better work. Because only thing is our collective thing. You have to keep on sharing your ideas. That is the reason why.
Even tracheal bronchus, sir,
Yes.
this year, 2023, in this Respicon, I find that all are stressing on it below 1 year, repeated attacks, not wheeze. This is also very important, I think. Tracheal
Madam, you are
bronchus.
very correct because I always, even though I have done a lot of bronchoscope, one doctor child they brought to me with a recurrent wheeze. And the child is around 7 months or 8 months, something like that. I said, we wait and all. But the doctor is insisted, no sir, you do the bronchoscope. Then when he says that, I have done, but I fail. He is wrong. I am wrong. Because we made a diagnosis of tracheal bronchus, that is a displaced bronchus happening from the right lateral wall. How it produces mean, it has a collecting tube. When the mucus is been getting collected, it is again come back to the trachea, that causes a wheeze. Actually, these are the cases with some postural drainage, you need to have some postural drainage and all, they become better. Not necessarily all the cases can be done for a surgery. And again, your MDCT plays a major role. I am not telling bronchoscope, I am honestly telling. And if you suspect, you go for MDCT. MDCT is the one that retrospectively analyze. And you have to go to sit with the radiologist. You say, I am seeing this problem is here. Then by retrospective thing, you can make a diagnosis.
Sir, can you show that slide once more, the tracheal bronchus, that slide?
Yes, yes. Okay,
Would you like
madam.
to see?
I'll just,
I want to make a comment, sir. Thank you for a very nice
yes,
presentation.
yes, go on, madam.
Sir, thank you for a very nice presentation, sir. Just want to throw, it's not a question, just a comment. So basically, sir, whenever we see that early onset visa, especially below 6 months, instead of wasting time for the nebulizations, it's always a thought for congenital airway malformation we should think of. And even I am also practicing the tertiary institute. Many times we get referrals, and at least we get a lot of these tracheal bronchus. And I mean, especially on auscultation examination, when we see there is a unilateral bronchi or unilateral. And that is also not the age for a foreign body, because these children are usually very cared. They don't start exploring the environment. So thank you very much, sir, for
I am
highlighting
very
that
happy
point.
because from my side, he has given an excellent thing. See, anything happening below 1 year,
Yes.
child is getting repeatedly admitted for V's. Your medical therapy fails, going different hospitals and all.
Yes.
There is maybe a possibility of Tracheobronchomalacia. There is a Tracheomalacia, Bronchomalacia, or a combination, or has been my friend pointing out that it may be some anomalies, accessory anomalies.
Yes.
These are a small thing.
Yes, sir.
Once you make a diagnosis, this repeated nebulization round the clock
Exactly.
is
And
not
it doesn't
necessary.
help also that, because many
Correct.
times people question,
There
what
the
are you doing? Are you posting bronchoscopy for everyone? So
Correct.
that is not the thing, sir. We should go in the right way. And just adding to the point, just CT. Many times if the radiologist is not trained to see those eyes, especially the adult radiologists, we don't have pediatric trained radiologists everywhere, tracheobronchus can be missed. And we retrospectively, then we go and see the CT properly, then we can see a branch coming
Correct,
out
correct.
separately.
You are very, very correct.
Thank you
Because
very much.
all the places we cannot do bronchoscope. I think now many youngsters started doing bronchoscope, but still there is a huge gap. Till such time you go for a good MDCT and all, and a luminal pathology can be diagnosed only by a bronchoscope. I am telling, your H-type of fistulas and all, none other investigation is going to help you. Okay? And if I still remember one child repeated admission from Nepal, brought by a surgeon, done a bronchoscope, H-type of, next day surgery done, is very happy. Everybody was very happy. Even the surgeon was very happy. Thank you very much.